is a normal human process of adjusting to changes in loss. It is experienced in so many ways. Support through grief, the importance of hospice and bereavement care. Tonight, On Call with the Prairie Doc.
Welcome to On Call with the Prairie Doc, health information based on science, built on trust. I'm your Prairie Doc host, Dr. Kelly Evans-Hullinger, and tonight we will be talking about support through grief, the importance of hospice and bereavement care. Grief is a complex emotion, and when grieving, health professionals can provide support. Hospice and bereavement care teams work together to provide comprehensive support to families throughout the entire grieving process. Along with them, social workers, counselors, chaplains, and volunteers are all integral members helping provide support and access to guidance and information during this time in your life. Tonight, we will discuss support through grief and take viewer questions. Thank you for joining our discussion. This evening, we are joined in the studio by Kari Sansgaard, the chaplain at Avera Health Dougherty Hospice House, and Dr. Francine Arneson from Avera Medical Group Palliative Medicine. Welcome and thank you so much for joining us this evening.
It's great to be here.
Yeah, we really appreciate your time. Kari, tell us a little bit about yourself and what you do at Avera.
Sure. Well, I'm a Midwest girl through and through, though I spent almost 30 years out west. And my training comes from social work through counseling to seminary. So I'm an ELCA, a Lutheran pastor, and spent a year of residency honing my chaplaincy skills back in 2015, 2016. So I have been in hospice care since then, working as a chaplain both in Idaho and more recently for Avera in Sioux Falls.
Great. Well, we're happy to have you here. Thanks for sharing your expertise. Dr. Arneson, you've been on the show a couple of times, but remind us about your background and what you do in Sioux Falls.
Sure. So I'm a neurologist by training, but I practice full-time palliative care in our cancer center. So I'm seeing patients in clinic, generally upstream, quite a ways of hospice care. We try to help with symptom management, making sure that medical care aligns with their priorities, and just offering extra support.
Great. We're great to have you both here. Before we start our conversation, we invite you, our audience, to submit your questions for tonight's discussion about grief, hospice, and bereavement care. Viewers can contact us three ways. Call 1-888-376-6225. Send an email to ask@prairiedoc.org or ask on our Prairie Doc Facebook page. We will work to answer as many of your questions as possible given the time available. Sometimes we receive more questions than we can cover, and we apologize if we do not get to your question. Your question will remain anonymous and no information is saved. Viewers can leave their name, email, or phone number to be entered into a drawing for our Prairie Doc publication, Perspectives from the Prairie, but it is not required to submit a question. The winner will be drawn and announced at the end of this program. Let's, start by laying out some definitions and so that we are all on the same page of what we're talking about. Franny, you talked a little bit about palliative care, which is what you do every day. Tell us what's different but when we're talking about palliative care and this other term hospice. Can you help define those for us?
Sure. So they both have similarities in terms of being very patient and person-centered. They both are comprised of interdisciplinary teams, so a lot of different folks on the team with different expertise. Where they differ is what the patients want is for their medical care at the time. So patients that are still wanting to do disease modifying treatment. So in cancer care, that would be chemotherapies, radiation, things like that. They are generally followed by palliative care, whereas folks that have a more limited prognosis, generally 6 months or less, and want their focus to be more on comfort, family, love, and not pursue those more invasive or disease-modifying treatments, they would qualify for hospice care.
Yeah, so it might concur to some degree, but you're dealing mostly with patients that are not on hospice in your day-to-day
Correct.
clinic setting right now. Okay, great. You work in hospice all the time,
Yes.
Kari. So can you tell us a little bit about the Dougherty Hospice House is actually an inpatient hospice. So like what happens there and what's the team that you're working with?
Also interdisciplinary, which
Yeah.
is wonderful. We have an in-house medical director, we have nurse practitioners, pharmacist, and then all of the things that you would imagine, social worker, bereavement team, volunteers, nurses, and aides, as well as chaplain. So when people come to the Dougherty Hospice House, it might be something they planned when they first admitted to hospice, potentially at home or in a facility, where they said to their family, when I can no longer ... It might be when I can no longer walk. I want to go to the Dougherty Hospice House. So that's how some of our residents come there. Others come in more emergent situations from the hospital setting. And so there are a variety of ways that people come there. And then the whole full gamut of care is offered as well, as is true in palliative. Spiritual pain is addressed, emotional, psychosocial, and of course the medical issues are addressed. And we have both acute and residential patients depending on how sick they are.
Yeah, so acute meaning maybe needs IV or more attention as far as symptom management.
Correct.
That kind of thing. Okay.
Yes.
And we're talking about hospice, a hospice house, which is a location, but that's really not what defines hospice. Who qualifies for hospice, and where is most hospice care delivered, Franny?
So most hospice care in the United States is delivered in individuals' homes, their own personal home. And I think of hospice care as you need two things to qualify. You have to have two physicians feel like your prognosis is 6 months or less if the disease runs its general course. You also have to want hospice care.
Right.
And so I think of hospice as broken down into kind of three different things. So it's a medical team, like Kari already described,
Right.
but then it's also a philosophy of care.
Right.
You know, you have to have a patient that truly wants comfort to be their focus, to avoid hospitalizations. They don't want invasive things done to them. And then it's also a benefit through most insurances, cover it really well. If you have hospice care in your own home, most of the time, the medical team, equipment and supplies and medications tend to be covered 100%.
Yeah, and I remember there being some sort of surveys published, this has been a few years ago, about what most people would want in their own deaths. What did those say? Where do most people, if you could choose where and how to die, what do we know about that?
Most people say they want to die at home.
Yeah, yeah.
And many are able to.
Yeah.
Yeah.
Great information. Does a hospice team address pain and symptom management at the end of life? So like you sit in on these team meetings in hospice. What do those meetings look like, and how do we work as a team?
Yes, the medical director really sets the tone and includes the whole team, looking for how are they doing physically, psychosocial, emotionally, and spiritually. And in terms of the physical pain management, what I hear them say a lot is we'll go low and slow, meaning the narcotics that we hear such bad things about generally in life are really intended for this stage of life, but are given in very tiny doses to help manage breathing, to help manage pain. And the goal is always to keep people as alert and as comfortable as possible for as long as possible.
Yeah.
And all of the decisions around the medicine are made with the family, and if the patient is alert enough, with the patient as well. So nothing is done without consent of family.
Yeah.
When someone's in comfort care.
Yeah.
I would like to say just a word about the word hospice,
Yeah.
if I may. In Latin, it's also the word hospice. And I think the meaning of it is helpful for all of us to think about in healthcare, because it means host and guest. And so when we walk into a room as a physician or as a chaplain, we are the guest to that person's body, to their space. And in a reciprocal way, we are the host to our knowledge and our training. And it's the root word for hospital. So at our best, I think at Avera, we really embody being a host and a guest, not just in hospice, but throughout healthcare.
Yeah. And you talk a little bit about really trying to honor the patient's preferences and what they would want, whether they're able to voice that or at the time they may not be able to voice that. How do you, in your clinic, guide patients and families through putting things in writing about these situations? What would you advise people in general to do when it comes to things like advanced directives, medical powers of attorney, and some of these things?
That's an excellent question. It's very much underutilized in our country, those documents, yet they're so incredibly important. I think of them as a gift that you give to the people that you love. Every adult, in my opinion, should have advanced directives, which just means planning for the future. If you were ever so ill or injured that you can't make your own healthcare choices, who would you want speaking on your behalf? And the most important part of that isn't actually the document. It's having that conversation with the person that would be making medical choices for you to make sure that that aligns with your own values and preferences. And these conversations have to happen more than once throughout our lifetime, because as we age and as we change and we have new diagnoses happen to us, our values might change and our preferences might change. And so it's a constant work in process to make sure that those are updated. But like I said, I feel like it's a gift to the family and loved ones, because if you're in a position that you have to make choices for another person, at least you're just following their roadmap instead of making the decision yourself.
It's a lot of pressure to be in that position if you're not really sure what the right thing is or what that person would want. And so if there's not a document in place, like a medical power of attorney, every state is a little different as far as who is the kind of legal default. In South Dakota, what's the hierarchy, if you will, of like the default decision maker?
Legal spouse, even if you're separated, adult children, then parents, siblings, and then other blood relatives next.
Yeah, and so I think as a primary care physician, when you know your patients well, I think that helps me guide those conversations, because of course in a lot of settings the spouse is probably the person they would want making decisions and the best person to do so. But if I know my patient and maybe they've never been married and they don't talk to their sister, that's the person that really should have in writing, this is the person who I would want making those decisions, because they might not have any legal right to do so if it wasn't in writing, right?
And we can get those documents from our primary doctors, right?
Yeah. So that's all good information. Talk to your primary care doctor about that. Good. What emotional and spiritual resources do you feel like are called upon a lot in the situations of the patients and families in your hospice care? What kind of things does a typical family need from you, the chaplain, or the team, and how do we deliver that?
Yeah, great question. They need for us to be listening, to be observing, to be asking questions. And I don't know if there's such a thing as typical, because grief will have its way with us. And so grief might come up as knowing my person is dying, I might be angry. I might turn toward the physician or the nurse in anger. I might turn toward a sibling in anger. 5 minutes later, I might be asleep. 30 minutes later, I might be crying. And so what I find is needed, at least in my role, is to really bear witness to wherever they need to go in their grief and to normalize it. Because sometimes people feel a bit crazy. Everything is out of control. They have no agency to determine what's going to happen to their loved one. And so lots and lots of out of control feelings can arise. And for someone who can be stable and calm and normalize all of those feelings can be a really helpful step in the process.
Good. We actually have some caller questions related to our conversation, so let's go to those. We had a caller from Spearfish ask, if you refuse dialysis, can you still qualify for hospice? Is this a consult that you've had, Dr. Arneson?
Yes.
Yeah.
Yes, if you're eligible for dialysis and that is a recommendation and you decide you want to forego that for whatever reason, most oftentimes you would be hospice eligible, and assuming that hospice is available in the area that you live, you could be admitted usually the same day.
Yeah, it's a great reason to be eligible for hospice if you choose not to use that. Good. We had a caller ask, how do you talk with your family that is resistant to having your family member put on hospice care? So I guess from your perspective, Kari, what is the best way for families to deal with things when there's disagreement about what should happen with their loved one?
Sometimes it is helpful to bring in a third party, whether it's a medical doctor or a social worker or a chaplain. But if that's not a possibility, my recommendation is to really start with iMessages. I'm feeling such and such, or I'm wondering about hospice. What are your thoughts? And if emotions arise, to really work on managing your own anxiety and staying calm. My go-to question when I'm in a situation that's tense, and I think it would be helpful in this situation, is to ask, can you help me understand? Hospice for some people means death, and a lot of people equate hospice with immediate death or giving up on our beloved one. So if there's a lot of tension, you might think the best way to love our grandmother is to do everything we can to cure and treat her disease. I might think the best way to show love to our grandmother is to stop that curative and move into the comfort lane. And we both love Grandma. So starting with what we share in common, I know that you love Grandma so much, I do too, and I sense that we're coming from different places. Let's slow this down and each share our perspective. And maybe a resolution will come in that conversation, and maybe it will need to be put off for a while. But all we can control is what we say and how we say it. So to feel a sense of integrity about, this is what I'm thinking, can you help me understand what you're thinking? That's the place to start.
And I mean, your team probably helps families work through some of these forks in the road about decisions about treatment too. How do you approach that as the physician in the room when you have maybe more than one family member?
Yeah, so
oftentimes
it starts with asking questions of the oncology team to make sure that I understand what they're offering from a disease-modifying treatment standpoint. But then we'll generally talk through like what those different pathways might look like, what common side effects they might have if they choose to do additional treatment, what other treatment options are there to promote comfort and to alleviate suffering, whether we're doing treatment or not. We try to focus a lot on their values, what they enjoy out of life, how they derive meaning, and just really get to know them on that level. When there's discord, most of the time listening is the best answer. People want to feel like they're being heard, and I agree with you. We don't have to solve all of these problems in one visit. Sometimes just a little tincture of time kind of sorts things out and allows people's emotions to calm down.
Great advice. Grief in hospice care can be a very emotional situation to navigate. Donna Buman, hospice social worker, and Lynn Kaufman, director of home health and hospice care, both from Brookings Health System, spoke with Prairie Doc about navigating this difficult time.
Hospice care is a philosophy of care that focuses on comfort and quality of life for people who have a terminal illness. Some people think it's a place, but it's not a place, it's just that concept of care, and we go to where the patient is.
A doctor must identify that an individual is appropriate for hospice care. Some indicators would be a 6-month or less life expectancy, or if a disease within the individual has run its natural course and the patient is looking for comfort-focused care rather than treatment-focused care.
I usually explain the hospice benefit itself in 3 main areas. So we've got people, equipment, and medications that are covered by that benefit. The people are the hospice staff that are going to come to see the patient, and that includes nurses who are really focusing on symptom control and comfort for the patient. It includes aides for personal care and bathing, social workers or extra support for the family. We've also got a chaplain that provides care for our hospice patients, and then we have hospice volunteers who can be part of that hospice team. So that's the people that come to the patient, but we've also got other people in the background that help us. So we've got access to physicians and pharmacists and dietitians to help us provide care too and be part of our hospice team.
Most insurances and Medicaid cover hospice care.
Hospice has changed a lot over your 22 years plus, but they're doing more now to help people have those conversations. So one of the tools I have as a social worker is a deck of cards that can help people have those conversations, and it will have a topic at the top that says, maybe at end of life, would you rather have some pain? So it's like ABC. Would you rather have some pain and be awake and alert, or would you rather have be sleeping and feel no pain? And family members can ask those questions and hear their loved ones' answers. Because again, most of us don't have a lot of experience with end-of-life situations and don't even know what questions we should be asking. And I realized there's a stigma about hospice out there. People think it's about end of life, it's for the dying, and it's for the end. But it's the journey. Not one of us gets out of this life alive. So let's prepare and have the best transition possible.
Great information. We've talked a lot about hospice already. I certainly get questions. Okay, maybe this is the decision we want to make for future care. What is that? You mentioned it as a benefit. So what does the hospice benefit cover, and who gets hospice benefits? Franny.
Sure. So most insurances cover hospice care. Medicare rolled it out as almost a trial back in the 80s, and most insurances have followed and followed pretty quickly thereafter. It includes visits to your home or wherever it is that you're living from that medical team. It includes equipment like hospital beds, walkers, wheelchairs, commodes, shower chairs, supplies like pads, Foley catheters, things like that, and then medicines, any medicine that the patient needs to be comfortable and to manage symptoms. Uninsured patients, most often, we can figure out a way to get them hospice care.
Yeah. But Medicare across the board is well covered.
Absolutely.
For the most part, this is something that's easily accessible for people.
Yes.
Great. The other theme of this show is grief and bereavement. So I guess let's talk a little bit about that, Kari. Can you tell us, I think, we've all, any of us who have lived long enough have experienced grief and I guess know what it is. Is there a good definition of bereavement, grief, either of those things?
If I had to choose one word to define grief, I would say love. Grief is a process we go through when we are responding to a particular incident. I often think of spiritual pain and grief as the same thing. They are a little different, but they're the same in the sense that it's anything that kind of breaks our heart. So I think even as children, when our first pet dies, or when a kid used to be our friend and no longer is, and we feel that sense of pain in our heart, that's grief too. But in this context, we're talking more about grief related to an impending death. We call that anticipatory grief. So the person who gets the diagnosis of breast cancer is grieving while they're alive, as are the people who love them. And that's what I was describing before. It can be big emotions, it can be withdrawal, it can come across in a lot of ways, but it's something that every human will experience, sometimes multiple times. And I think one of the teachers for me has been, well, all of my teachers have been people who've endured hard times and have lived through grief. And one of the things I've learned, this from Nora McInerney, who used to live in the Twin Cities, and in the course of 6 weeks lost a pregnancy, her husband, and her father. She talks about how we don't move on from grief, we move forward with it. And I think if we could normalize that too as humans, that if we get 3 days of bereavement in our job, that our culture might expect we should be over it in 3 days or 2 weeks or whatever. But instead to recognize we're all living with grief. You asked about bereavement. In the Midwest, where our culture sometimes prevents us from being very forthcoming about our feelings, I have learned to ask people pretty focused questions when they're grieving. Instead of, how are you doing? The answer will generally be,
fine.
I might instead ask, what has been the hardest part of today? Or what has been the best part of today? Or I sometimes use what I've called the menu method. Would you say you're feeling more tired, more sad, or more numb today? And generally people will choose from that or say something else. We are not made to grieve alone. We need people to support us. And in hospice, we are federally mandated, which I think is awesome, to provide bereavement support or grief support. So if our grandmother has died and we have both been very active in her life, we might both receive letters, phone calls, opportunities to join a grief group. And for people in more isolated or rural areas, that can sometimes be done via Zoom. So for 13 months after a loved one dies in hospice, bereavement support will be offered. Everything in hospice can be declined, except for the nurse visits. I think by law once every 14 days, or you can choose to go with the comfort option, be in hospice, and then change your mind.
Right.
Say, oh, there's a new treatment I want to try. So I think that's important to know too, that you're not stuck in either the curative or the comfort lane.
Yeah.
You have agency to choose. But yeah, grief is with us for the rest of our lives. We're never done.
Yeah. We have a few more email and caller questions, so we'll transition to those. We had an email question. What illness has palliative care? So I guess let's start there. And when does that transition to hospice? So I guess you do full clinical palliative care. You're really not doing hospice care as part of your job right now, Franny. What are some typical illnesses that for which you get consulted to help with management?
So it's incredibly broad. We would use the definition any age and any stage of serious illness, and probably some of the most common diagnoses that we get referrals for would be cancer, late stage cancer, advanced heart diseases, advanced lung diseases, advanced neurological diseases like dementia, Parkinson's disease, multiple sclerosis. We see a lot of patients with, end stage or advanced kidney or liver diseases. In the hospital, our team sees patients who are admitted to the hospital, and they might see traumas. They might see acute strokes. They might see somebody who has an overwhelming infection. So it's a really broad patient base that we see. I've seen 20-year-olds in my cancer clinic, and I've seen 98-year-olds in my cancer clinic, and really everything in between.
Yeah. And I think, you mentioned how things have changed in the span of your career. I think we as physicians have gotten better at recognizing the benefits and utilizing your teams in palliative care too.
True.
Yes.
Very true.
You can tell by the volume of your patients, right?
Yes.
Good. And then the other part of that was, when does that transition to hospice care again? Like, this is really individualized, right?
Absolutely. It should be patient decision-led. However, as physicians and medical teams, I believe it's our role, our duty to our patients, that if we feel they meet the criteria for hospice care, it should at least be brought up and talked about. It doesn't mean that makes sense that day or even next week or next month, but if we truly are worried that our patient has 6 months or less to live, it's something that they should be offered because it's a benefit that they've paid for.
Right. And maybe it's never been presented to them as an option. We have a caller question that kind of stops me in my tracks. Kari, this caller asked, how do I tell my family I want to go on hospice? Well, how would you advise someone with that question?
Wow, yeah. Again, when we understand hospice as part of the process, one of my favorite definitions comes from a philosopher whose name escapes me, Eckhart Tolle. There it is. Death is not the opposite of life. Death is the opposite of birth. And when we frame our lives that way, death becomes a natural part of the process. And so I would recommend talking about what my hopes and dreams are. When I am near the end of my life, I would like bouquets of hydrangeas around me, or I would like scented candles of vanilla to be burning, or I would like particular music, and these are the people I would like around me. And then to talk again about, I have been living with stage 4 kidney disease for the last 20 years, and I am ready to be done with dialysis. I've talked with my doctors, and I am ready to focus on spending as much quality time with all of my family and friends as I can. And I want you to know that. And then maybe have the time thing again. Think about it, and let's come together again next week. Here's some information about hospice. People can be in hospice for years. The medical team is looking for a decline. That's what we need to be charting to. Increased sleep, decreased weight. And for some of us, we go down, we decline quickly, and other people have a very, very slow progression. So I think that information again, this is what I receive. All the years I've been employed, I've been paying into Medicare, and now this benefit is for me. This is my desire. What questions do you have? What would be hard for you about this? And again, it doesn't hurt to have another person there with you, your pastor or a good friend, or this is my neighbor whose husband was in hospice and this was their experience. To have an ally when possible.
And if it becomes continued challenge, you can ask for a palliative care consultation. You can ask for a referral, because that is what our teams specialize in, is helping you to navigate that difficult conversation with your family and giving you the time that you need to make sure that the right decision is made for the patient.
And I know even here in Brookings, we don't have you here, but we can always consult and do a virtual visit or whatever. But if I had a patient in this situation, I might say, you know what, Lynn, who was on the show here a little bit ago, she will come to your house and present what is hospice, what would happen if you did decide to admit, and what would be the benefits you get. She will sit down and talk to your family members and answer their questions, and then you can make a decision. You know, it's really not meant to be pressure filled about that.
Generally, a nurse and a social worker will go and offer the information, and sometimes they move right through an admission that day, and other times the family or the patient says, yeah, I'm not ready for this yet. And as you say, there's no right or wrong. It's very much the decision of the one with the terminal diagnosis.
Yeah, great. Prairie Doc spoke with Dr. Dan Mark, a specialist in pediatric palliative care at Sanford Health in Sioux Falls, about his work and how he cares for his patients and families.
Pediatric palliative care is similar but a little different from adult palliative care. I think a lot of people think of palliative care as end-of-life care. And in pediatrics, thankfully, not many children die, at least especially not compared to the adult world. What happens there is, and so in pediatric palliative care, there are a lot of children who the children and the family are going through long, difficult medical situations. And we view our role as supporting families, walking with them through long situations or difficult situations, or sometimes just medical situations that have a lot of unknowns to them. And so it's a very supportive role, and we try to support families through a lot of the difficulties, a lot of the strife that can happen through being involved in the medical system.
Pediatric palliative care may start at any age, from parents who are pregnant with a baby who may have medical difficulties to children and teenagers.
I'd say the biggest challenge is that the idea of it sounds scary. It sounds scary to medical providers who are nervous about what the implications of referring to palliative care what they might appear like to families. And I think families are nervous about who this new team is that's coming in to meet them.
Insurance often covers pediatric palliative care.
I think one of the main things that we emphasize is giving the child a voice. And some children aren't old enough or medically able to speak or share what's important to them. But we often emphasize what would be important to that child. And either giving the parents the authority or the freedom to share what they think is best for their child, or allowing the child to share some of what's important to them, and really emphasizing that the child is the center of the care and the most important person in the room.
Great information again. We have gotten some caller questions, and so we really want to answer your questions. We'll try to get to all of those if we can. We'll see how much time we have here. We had an email question. It's such a great question. It's been a few weeks since my neighbor, whom I am friendly with, lost her husband. She's being fairly reclusive. What can I do to help her without being too intrusive? What advice would you give? What? I mean, everybody's different, obviously,
yes.
But
I think so often we're afraid of doing the wrong thing, and so then we don't do anything. So I think it's important to continue to reach out in a gentle way. Sometimes when people are grieving, it's hard to make decisions. There's that fog that can set in, and so one way to try to provide support is to say, I'm bringing a meal. Would you like me to drop it off on Tuesday or Wednesday? When we ask an open-ended question, like, I'm here if you need me, or let me know when you need help, that's probably just about us trying to feel better rather than about really trying to do something helpful. And just to let that person know over and again that you're present. Generally, it's best to say, I'm going to leave it at your doorstep, because the idea of having a conversation with someone early on is just too exhausting for most people. One of my friends talked about a neighbor just showing up and shoveling her snow, the snow on her sidewalks, and that's what she needed. So those kinds of acts of kindness, continuing to say, I'm here if and when you're ready to talk, even if you don't get a response for many weeks, I think can be really helpful.
Yeah, that is, I think, good advice. It always is interesting to me. Grief being such a universal human experience feels so lonely to the person going through it, right? So just doing something and not allowing that person to feel alone is probably the most that you can do.
And also maybe recognizing that some of that alone time is also necessary. We have to feel the feelings, and they're hard.
Yeah, good. This is a great question too, one that I feel like I encounter a lot. A caller asks, I am a caregiver and my spouse is coming to the end of life. How do I prepare when my role has been so much caregiving for the last few years? How do you talk to the caregivers in your clinic?
That's a form of grief as well. Yeah. Because you're losing an integral part of how you identify with yourself and your role. I lean on my team a lot to help with that too. Making sure that people are told when they're caregivers how important breaks are along the way, so it's not the only thing that they have in their life. We talk to caregivers a lot about that. It's important for you to go have your nails done, and ask a neighbor or ask a friend or a relative to sit with your loved one while you do that small thing for yourself. That's a tricky question. I don't know if you have other thoughts on that.
It really is tricky, and I think caregivers are the hidden sheroes and heroes in our world who are very isolated often. I think the first thing I would say is to take one day at a time and to really be gentle with yourself. Most every caretaker I've ever spoken to gets so frustrated, and it will inevitably at some point come out toward their loved one. Nobody's angry at their loved one. They're angry at the disease. They're angry that they're sleep deprived. There's so much frustration. And again, we generally blame and shame ourselves for those kinds of things. So to say, this is a really hard role, like you're saying, I echo what you say. Take time for yourself now, practice tending to yourself so that when that time comes, it won't feel so strange. I think that's a particularly hard form of grief, and to ask for help from people is important for support.
Yeah, good. This is actually a related question. Can we talk about how sometimes it feels like it is a relief to have a family member pass after a long illness? And I see this dichotomy in my patients who are caregivers. Sometimes the guilt is sometimes the grief is very complicated and intense, and sometimes there's almost a guilt because there is some relief and a lifting of burdens. This caller says, I feel guilty sometimes for it finally being over.
I talk about this every day, every day, because it is a relief. It's a relief that your loved one is no longer suffering, that you've seen their quality of life decrease. And so we can say culturally, in an acceptable way, I'm relieved for my person who's died. What we are not yet saying very well, and I think ought to, is, and I'm relieved for myself, because now I can return to a more ordinary life. I think it's possible, and I preach this to people, to really love someone and also to feel relief for yourself. And I model that. My mother died in October, and I say I'm relieved that she's out of pain, and I'm also relieved for myself. I realized after she died how much energy I was putting into worrying. When's her next appointment? Should I call her today? I wonder if she has picked up her most recent medication. That is all gone, and that is a relief for me. It has nothing to do with how much I love my mom.
Mm-hmm. Yeah, great. So you're not a lone caller, and a support group might be a really great place to voice some of those things too. We had a great email question. How is grief different from depression, and when should my family members seek medical attention for their grief?
Well, this will probably be for both of us, because depression is certainly a medical diagnosis. We talk about it sometimes in my world as complicated grief. It's tricky.
Yeah. The symptoms are many the same, right?
They are, and I think when you're listening to your friends and your family who are checking in with you, saying to you, I'm not seeing any movement over the course of some months. Have you considered checking in with a physician? And then the diagnosis may come and some medication. My doctor said to me, when our serotonin drops low, it usually can find its way up again, but sometimes it doesn't. So,
I think that one of the keys is not seeing some forward movement over time, continued isolation over many months, and one of the words that's important is if people have a feeling of hopelessness. We worry a lot more in those situations, and that would warrant a more detailed evaluation and offering medication, counseling if they're not already doing that. I agree support groups for this purpose is really helpful if they're willing to leave the home and engage in that. But you're right, it is not just a simple answer like looking at a blood sugar. It is a very, very complicated.
There's not
a blood test for
line that you jump from one to the other when you step over it. I imagine you deal with this, now we're talking a little bit about after a death or a loss, but probably your patients facing these difficult diagnoses or have grief, and you have to decide when it's more than grief or depression, and the patient's still battling their illness, right? Yeah.
Right.
Yeah.
So we do a lot of formalized depression screening tools for our patients because it does tend to go hand in hand with a diagnosis of serious illness. And generally, I would pull the trigger on offering treatment for that if it's overwhelming and they're feeling a lot of hopelessness, they're feeling a lot of despair, they're feeling like regardless of things that they're doing that might bring them joy, they have a lack of sense of joy like ever. So I use the word overwhelming a lot when I talk to patients. Is it feeling overwhelming? Are you feeling sad and down more often than what you're not? Those would be, kind of reasons why I would talk then about medications in conjunction with counseling.
Good. We have 4 or 5 minutes left, so we'll try to keep getting to the email questions. There's an email, please address death with dignity and how South Dakotans can have more control over this process. We talked a little bit about documents. What advice would you give the general person out there about documenting their future wishes?
As I mentioned before, I think that the conversation that you have with your family is the most important piece. And it's not just with those folks that you designate as your medical decision maker. I recommend people talk to anybody who thinks they should have a say around your bedside, whether you think they should or not. So in South Dakota and back in Tennessee too, we would always talk about, the sister from California calls and, starts making a mess out of the plan. So making sure that you're being inclusive in who you have those conversations with. And just keep in mind, dying with dignity means very different things to different people. I meet people all the time that their preference is they want to die in an ICU on a machine. And there's nothing wrong with that. But making sure that your family knows that.
Yeah, good. A few more minutes. Is there grief counseling in hospice and palliative care? Easy answer, right?
Yes, there's grief support. It's definitely part of hospice, and it starts the day of admission, we start providing bereavement support. And then again, the day of death, we don't all disappear. Right. That support continues. And we also then refer people if they're wanting a deeper engagement of grief process with a trained therapist.
Yeah, good. This is a great question. A caller from Centerville asked, what supports are available for patients on hospice without family to care for them? How do you navigate that situation?
That's complicated, and I generally end up leaning very heavily on my social work colleagues to help navigate that. You know, oftentimes the hospice team can still go into the home and offer a lot of support and help people stay functional, independent for as long as possible. And then when the time comes that they can no longer manage their care, then transitioning to a facility where there's, you know, more nursing and around-the-clock caregiver support is generally what happens.
Yeah, I echo that. And when we know someone doesn't have people, we as a team lean in more.
Yeah, good. Email, last question. How do I deal with some of the physical reactions coming with grief? This person in particular has sleep problems. I would say sleep and appetite are probably the most common things that I see in grief. How do you help people with that?
They need to see their primary care doctor for sure, because oftentimes as a caregiver, you neglect your own medical needs during that entirety of caregiving. And so just visiting with your primary care doctor and being transparent, open, and honest with them about what you're experiencing, primary care is fantastic. Most of the time they'll be able to help.
Yeah. Something we see a lot of and can talk about. Usually I'll ask the question, you know, we will talk a lot after an event like that, and I will say, okay, I hear that you're having trouble sleeping. Do you feel like you need help with that right now? And, you know, there's various, you know, things that we can help link to counseling and that kind of thing. So I would agree with that. Talk to your primary care provider, but very common along with grief to have some of those physical symptoms. Yeah.
If we could start thinking that grief is part of the fullness of life, that we have grief, we all have it, and we also then appreciate the joyful times, I think that's a good starting place.
Yeah, good. Our winner tonight is Lynn. A book will be sent to you shortly. We'll be back after this.
Overwhelmed with the amount of information available? Not sure which sites to trust? Head to the Prairie Doc YouTube channel today to access all previous On Call with the Prairie Doc episodes. And make sure to join us most Thursdays on SDPB or streaming on our Prairie Doc Facebook page.
Thank you to our guests, Kari, Sansgaard, and Dr. Franny Arneson, for volunteering their time to help us learn more about grief, hospice, and bereavement care. If you would like to see and hear more episodes of this program, please like and follow us on Facebook, Instagram, Threads, YouTube, and TikTok, or visit us at prairiedoc.org. Look for Prairie Doc perspectives in your local newspaper and online. Listen to us on Prairie Doc Radio on SDPB Sundays at 6 a.m. and 1 p.m. And be sure to look for the podcast of this program, Prairie Doc On Call, wherever podcasts can be found. From all of us here at On Call with the Prairie Doc, thanks for joining us for another episode of health information based on science, built on trust. Until next time, stay healthy out there, people.
Whether it's from stress, anxiety, depression, or thoughts of suicide, the mental health of America's adolescents and teens has been growing steadily worse. Teen mental health crisis, what we can do to help. Next time on Call with the Prairie Doc.
My name is Dr. Tad Jacobs, and I serve on the Healing Words Foundation, the nonprofit that runs Prairie Doc programming. Our mission is to enhance health and diminish suffering by communicating useful, science-based information respectfully and compassionately. Your donation supporting Prairie Doc programming makes an extraordinary difference. Gifts of any size enhance its impact in our state and beyond. Thank you for your generosity.
Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Sanford Health, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health,